But let's officially get started at this time. I think we have most of us in the webinar. Some still may show up, but let's talk about today's topic. When it comes to patient safety, compliance, and infection prevention, few topics are as overlooked and as critical as instructions for use, IFUs, and directions for use, or DFUs. Now, these documents are more than just fine print. They're legal, technical, and operational lifelines connecting manufacturers, cleaning professionals, and healthcare facilities. And everyone on our webinar today are involved in some degree with those verticals. But how often are they truly understood or followed as intended? Because if they're not, what's the point? So in today's session, our panel of healthcare cleaning and disinfection experts will unpack how IFUs and DFUs shape real-world cleaning, disinfection, and reprocessing workflows, and what it takes to close the gap between regulation and daily practice. So I'd like to mention who are on our panel today, and then we'll get into our questions. We have Joanna Mills, the Director of Infection Prevention at John Muir Health. Joanna, welcome.
Thank you very much.
Glad to have you.
Glad to be here.
We have Barbara Strain, the principal at Barbara Strain Consulting. Barbara?
Yes. Good morning, Jeff. Thanks for having us on.
Absolutely. And last but not least, Sarah Wilkerson, the Systems Executive Director, Infection Disease Management and Prevention at Providence. Sarah.
Good morning. Thank you so much for having me.
Sarah wins longest title, just so you know. All three of our experts today understand today's topic and are ready to share their expertise with you. So let's get right into our program and let's define the essentials to start with. And Joanna, will ask you to answer this question. For those less familiar, what exactly are IFUs and DFUs, and why are they so critical to infection prevention and healthcare compliance?
So IFUs is a portion of the FDA validation process and DFUs, directions for use. The validation process for devices and healthcare associated items that are utilized in healthcare. The reason that they're so important is because not just the use of the item that the FDA talks about in terms of is it being used for the purpose that it was designed, but also the safety and efficacy of the product itself. Included in that are elements of reprocessing, cleaning, maintenance of those devices. And it's not just medical devices that are utilized in care, but also the items that are utilized in the patient care environment. So things like beds, IV poles, those items and surfaces that are in the healthcare environment that could potentially harbor organisms or really have an impact on patient outcomes. The problem, however, is that the IFUs are not a focus of the manufacturers. Obviously, the technical items are, and the other issue with IFUs or DFUs are that the FDA doesn't necessarily enforce those items. So there's no real follow-up. There's no real insurance that those items are being followed. And we all know, those of us in healthcare, that if they're not, it could really have catastrophic effects on patients relative to primarily infection, but also misuse.
Good information. Very important to understand what we're talking about today. Thank you for that, Joanna. Sarah, we're going to go to you on the next question, and feel free to add to that comment as well if you'd like. But talk about the requirements related to regulatory agencies related to IFUs. There's the FDA, EPA, a lot of acronyms. Talk about that.
Yeah, of course. So the FDA, or the Food and Drug Administration, really mandates what the manufacturer needs to do for medical devices. They need to ensure that they're safe and effective claims around cleaning, disinfection, sterilization, and reuse of those devices. And the IFUs must include step-by-step instructions, visuals, warnings, what is the proper storage, disposal guidelines, as well as compatibility. The EPA, or the Environmental Protection Agency, on the other hand, regulates disinfectant products. So these are products that are used in healthcare. And again, the manufacturer must provide those instructions for use, including how to dilute the disinfectant, how to apply it, how long it needs to stay on the surface, and then if there's any safety precautions that they need to put in place. Now, on the other hand, CMS and Joint Commission, while they don't directly regulate the instructions for use, they enforce compliance. So going back to what Joanna was just mentioning with that risk to the patient if these IFUs are not followed, and the increased risk for infection if they're not followed. So with CMS, they have conditions of participation, and for Joint Commission, they have infection control standards. And these facilities are really required to follow those nationally recognized guidelines, follow the manufacturer's instructions for use for sterilization and disinfection. And then, as I mentioned, those non-compliances with the IFUs really put the healthcare facility at risk for citations from those organizations, as well as those potential infection control breaches that can then lead to outbreaks and infections in our patient population.
So with so many involved, let me ask you this, Sarah, as a follow-up. Who's ultimately responsible for this regulatory compliance?
Yeah, that's a great question. It is something where it is a shared responsibility. Of course, the manufacturer has that responsibility to do all the things that we just talked about, but ultimately it ends on the healthcare facility, the end user who's actually using these products, to ensure that they're following the instructions. It's really up to the facilities to make sure that the staff have access to those instructions for use, that they know how to they understand how to read them and utilize them. And then, as I just mentioned, if there's a deviation, it puts those patients at risk. So facilities have to justify why there's a deviation and document how it's been mitigated. So really following up when there's conflicts between the instructions and what the facility can do in their current space. So having that documented, written down, if there's a deviation, that the manufacturer supports that deviation. This can be really time consuming, unfortunately, for the end user to do all of that additional research. And oftentimes the manufacturer doesn't have that information. So it can really put the healthcare facility in a hard place.
Which is why we're talking about it today. Thank you for that, Sarah. Now, Barbara, you've been so quiet. We're going to go to you next. And because of this, we're going to give you a really long question. You ready? All right. So today's topic has been referred to as the Wild West when looking at regulatory requirements for manufacturers to test their materials and products for compatibility with standard disinfectants. Would you agree with that? Yes or no? And elaborate on this for us.
Well, since I'm a native of California, Wild Wild West kind of fits. It really is. So in addition to being a consultant, probably people wonder, well, why is she qualified to be here? So half of my career, 20 some years, I was a microbiologist in clinical laboratories in hospitals, working closely with infection prevention and control, infectious diseases. And part of all of our principles was disinfection, cleaning, sterilization, and things. And the other half was then spent, if anyone's adding up, that's a long time, two halves. And I did value analysis. So I directed a whole program for over 20 years of how we make these decisions, which will come up a little bit later in the webinar. But I wanted to tell everybody I do have qualifications other than I like to tell people how they need to do things. One mentioned what Sarah said is it goes to the Wild Wild West, is all of the regulations, guidelines, and things are basically frameworks to the manufacturers and others, but they have their own lane. They have a hard time sort of then looping everything together so that it's not that, FDA might say this and that, and then they say, now pick up on whatever, EPA says here, then you read that, etc. So there leaves a lot of gaps for interpretation of what testing and things needs to do. So in your long question about everything, yeah, it's a wild, wild west, but there's a key factor that we're leaving out is the durability aspect. Some people confuse compatibility, which is the disinfectant, the active and non-active ingredients, and does it do anything, and is it compatible with the materials? The durability is so important because that goes to what in the real world are people actually doing and following, and how often are they following? Daily, 4 times a day, 10 times a day, depending on the device. And if you look at the AHA, American Hospital Association, estimated useful life for assets. So I'm going to use an example of an IV pump through probably most of my answers today. But the IV pump has a 10-year life on it. However, we have seen damage, which is low risk damage, within months of instituting a new IV pump to less than 2 years of more moderate risk to high risk damage. So 10 years kind of goes out the window at that point. So it is a wild, wild west because things aren't very connected. And I won't go into any more stuff because now you've wound me up, Jeff. So,
Well, since you're all wound up, we're going to ask you one more question.
okay.
So, what are the challenges that healthcare organizations deal with related to product selection, both device and disinfectants, costs, and materials compatibility? And you can talk about IV poles if you like.
Well, it's IV pumps is
Pump.
what I'm talking about.
Yeah,
Yeah,
I'm
the
not.
poles,
I am not the healthcare expert here. That's for sure.
that's okay. You were just quizzing us. I know that. Um, this is a really, really crucial question because as my value analysis hat that I had on, I would gather the end user groups that were going to be affected by these sorts of decisions. So I've gone through a couple of IV pump and other pump and monitor projects over my career, but you need to make sure that all of the stakeholders, so you can't just say, well, we'll make the decision and then we'll bring in these other people later when we talk about implementation. Everybody needs to be at the table, whether it's the end user nurse, whether it's the pharmacy that's going to have to put little formularies in there, or it's the person that's going to clean it, which can be a variety of individuals. And then biomed, who's going to have to take care of it. So all those sorts of people need to be involved, whether they're clinical or operational. And then the disinfectants, you have to look at what you're going to do for the disinfectants compared to what you have on hand. So decision making for disinfectants is also a big deal. Infection prevention and control sits at the table for all of these discussions, whether it's for the device or whether it's for the disinfectants or the cleaners we're going to use. But and sometimes we try to make a decision that's, well, let's crosswalk this and we'll make it easy for people to do what we think is the right thing, but is it the right thing? And some of our answers will elicit some of that today. You also have to look at total cost of ownership and all those sort of factors related to all the maintenance and dollars and cents and the whole value to the organization. What are all the materials used in the environment, as Joanna mentioned? And then there's changes over time. If you're thinking about buying it for 10 years and today your environment in your hospital is X, Y, and Z, and in 4 years your environment may have changed drastically, does all that still work and all of the cleaning and disinfectant and things? And then I'd be remiss as a microbiologist not to mention those microbes don't behave. They don't care what's written on the piece of paper. They don't care what's really going on. They want to survive. So we either have novel organisms like COVID and other things, plus all of the resistance that's happening in our microbial world. And does all that world still fit in with all the decisions we make?
Barbara, great information. I'll let you wipe your brow and calm down a little bit. No, seriously, good information. Thank you for that. We'll get back to you in a few minutes. But Sarah, let's tee you up with this question because communication is important. So let's bridge the gap there. Where do you see breakdowns most often occur between manufacturers, healthcare facilities, and frontline staff when it comes to following these IFUs, today's topic?
Yeah, there are so many places where it breaks down, unfortunately, with the current process. Just for example, healthcare facilities may have trouble accessing the actual instructions for use. And when they do, it might not be the correct version. Maybe they've updated it. Maybe it's a US or an international version of the instructions, and they actually have disinfectants that are not approved for use in the US. So making sure that they've got the correct version of the IFU, especially when we're thinking about older equipment or even discontinued devices. Other things, it can be challenging just because it may be really embedded into the manufacturer's website. So you have to dig deeply to try and find these. They may have updated it and not sent that information to the healthcare facility. So they may be following instructions that are no longer valid. Additionally, there is not a standard format for how the instructions for use are laid out. So it can be really confusing for the staff to be able to interpret it and apply them correctly. Additionally, the manufacturers don't always include frontline teams with how the instructions are developed. So there's no accountability for real world workflows. There's so many steps that it can be challenging to actually follow those instructions. There can be ambiguity in who's responsible to do it. So there may be missteps or delays or even that increased risk of infection if steps are missed. So for example, our nursing staff may have responsibility to start the cleaning and the unit, but then the item goes down to sterile processing and they finish the reprocessing of that item. So there can be that handoff piece that has to be incorporated. There may be specific proprietary products that are listed in the instructions for use. So for example, a glucometer that our facilities use, they specifically call out a product by the manufacturer's name versus what type of a disinfectant it is, even though multiple manufacturers make the same disinfectant. So let's say it's a bleach, a 10% bleach solution. We have multiple types of bleach solutions out there. So that can make it really challenging. I think, Barbara, you mentioned this, that if the facility doesn't have access to that specific product, then they're outside of the IFU. So that's where really, when there's these conflicts, that we have to bring the teams together to have a conversation about it. Just another area where there can be breakdowns is if there's a conflict between IFUs. So let's say, for example, endoscopy or endoscopes that are utilized. They have brushes that are then used to clean those scopes, but the IFU for the brush may be different than the IFU for the endoscope. So there can be challenges there. So definitely some opportunities to improve between the groups for the communication.
I say no kidding. Wow. So
And may I add that, all of the things that Sarah mentioned are also complicated by who the end user is. You mentioned nursing, but there's other staff. There's X-ray techs and all kinds of people who go into patient rooms and or healthcare environments that are responsible for their piece of equipment, but they may not even know the detail and complications associated with how they're supposed to clean the item in the first place, primarily because that's not in their purview. That's not something that they are focused on. They're focused on taking care of the patient, and somebody else does the cleaning. But the reality is everyone plays a part, and the piece for those gaps that are the most critical are the education piece. And we all know that, education can be costly, time consuming, especially with educated and technical personnel that are highly trained and require, a certain degree of competency and return demonstration and all of that. So it gets really complicated with those gaps. Barbara mentioned biomed. Biomed has the added responsibility of the functionality of the device itself, electronically and otherwise. And what impacts that function can be related to the chemicals that are used on the exterior. If they penetrate, if they damage the surface, if things get cracked from extended use over time. And so it makes it a really complicated topic where so many people are involved in the correct application of the IFU that, nobody's in charge. The Wild West, as you said before, the Wild West with firearms, it makes it even worse. So it's really, it's distressing to me, but only because I'm the one that, the buck stops here as far as, and then Sarah can talk about that as well as everyone else. But you take that responsibility really seriously in terms of what are we doing? How are we affecting the outcomes of these patients? And that's, that's my focus, obviously. But if you don't have help with that from the manufacturers, from the chemical companies, from even the service industry, you're dead in the water. What can you do? You're out there on your own without a lifeboat.
So sticking with your line of thought there, Joanna, what are the mistakes that you see hospitals making in interpreting or implementing IFUs? And talk about the cleaning teams, the balance that those requirements need with real world constraints, timing, staffing, all the things that have to come together to make this work.
Well, there's the example that I like to give are the EVS staff, because those are the folks that conceptually we think are responsible for cleaning. Okay. Everybody in the hospital says, oh, I don't clean. That's somebody else's job. Well, the reality is everybody cleans, but let's not go there at the moment. The EVS staff go into a patient care environment. There are devices, technical items in the rooms. There are things like pumps that control stasis, venous stasis in the legs. There are heaters, coolers. There are all kinds of devices that are maybe not specifically healthcare associated, like the remote for the TV and all of those things. And an EVS person is responsible on a daily basis and upon discharge of the patient from that environment to thoroughly clean, to make it ready for the next person coming in. Well, in my opinion, that's an unrealistic expectation for one person to be able to do that. Not only that, but the time it takes for that to occur in terms of what we call the turnaround time. Turnaround time relates to, how long it takes for that room to get ready for the next person to go in. And that's money, that's admissions, that's, the lifeblood of, organizations. The other thing is, in the OR environment, okay, we're talking about pardon my expression, blood and guts, okay? Let's be real about this. We're talking about slime everywhere, splashing, all kinds of gross, disgusting things. Sorry, I divert. And but the issue is there. So now you have one or a couple of people in there in between cases of a surgical procedure. You know, everybody considers the OR a sterile environment. Well, the sterile environment is significantly compromised by the person who was in there in the first place, okay, right before you. And so the turnaround time is money in every situation that it takes to thoroughly clean it may not be in line with some of the parameters that are set by the organization. And so, and that's just one example of some of the gaps and the difficulties associated with it. You know, we talked about training. That's a whole different ball of wax. I could talk about that for centuries, but, you know, and that's just one example. We're talking about nursing staff who, frankly, are concerned with taking care of the patients, clinical interventions, and all of the things that they need to do to monitor the patients. They all include devices. And the next person coming on the shift, okay, may or may not know that they're touching something that somebody else touched that may be contaminated. And so conceptually, there's so much to be dealt with. Frankly, in my role, I get really overwhelmed by it, frankly. And, you know, and how much I can really impact some of the things that need to happen when it gets so complicated. Sorry to be long.
Listening to all this, I'm glad I chose the career I'm in and not what you folks do. Hey, Barbara, there's a question in the chat from Michael. Can you see it? I'd like to come back to that in a second.
Okay.
After
right.
Sarah takes the next question. But if you want to read that and think on that, we'd like to address that if we could. But Sarah, let's have you talk about training and accountability because we talked about how education is expensive. What kind of training or documentation practices help ensure that IFUs are not just read but followed consistently, especially during those dreaded audits and inspections?
Yeah, that's a great question. As Joanna mentioned, we could talk about training for a long time, but I'll try to be concise. I mean, the biggest thing is making sure that you have a centralized repository of the IFUs. Make it as easy as possible for the frontline team to have access to those. And then utilize your contracts with the manufacturers to have them come in and provide that training. Oftentimes, facilities don't have the staff to develop the training. And so we can utilize the manufacturers who oftentimes have that training readily available to come in and provide that for the staff. Additionally, making sure that you're ensuring that you have competencies completed. Joanna mentioned that as well. So this is making sure that the teams not only can review the instructions, but then they can actually put it into action. So it's a little bit of the for nursing students, you learn the do one, see one, teach one method. So a lot of times having somebody who becomes the super user and can then help to train the rest of the staff in an ongoing basis. Things like placing checklists or procedures that really simplify the IFU into a few steps that's placed in the location where the team is going to be doing the cleaning or disinfection can be really helpful. Also just training the staff how to interpret the IFUs, give them a forum to ask questions, really make sure that they understand those details. And then do internal auditing, not just waiting for CMS and Joint Commission to come in and make sure we're doing it right. But there's things that the teams can do on a regular basis. So back to endoscopy in our endoscopes, they can do cleaning verification. So after they've done all of the steps that are required to clean it, they can do checks with things like protein or ATP to see if the scope was actually cleaned to the level that we would want it to be before it's disinfected. There's also putting audits together that the internal team, infection prevention, quality, even the leadership for the department can then go in and validate, are you actually following all the steps that you said that you were going to? And do that on a regular basis, especially those high risk items where we know it's prone to deviation from the steps when there's so many steps in place, making sure that you're going in and revalidating that the team knows how to do the work, that they know how to clean and disinfect the item, and they're not missing any steps. And then, as I mentioned earlier, when there are those conflicts, with the IFUs, having the team reach out to the manufacturer to try and mitigate those as soon as possible.
Back to communication, sounds like right there. Barbara, I know we're tossing this at you with unexpectedly, but if you're ready, the question from Michael is, does this give rise to the development of upskilled patient environment hygienists who are highly trained in cleaning medical devices and cover the gaps between medical and EVS teams? I read that because some on our webinar may not be able to see the chat. So
Great.
Go
Thanks
ahead.
for reading that. So, Michael, you've given this some thought, and it sounds like this is something that's been germinating in your organization and stuff for a little bit. So there's a pro and con to the answer. One is, wouldn't it be nice if infection prevention and control had others who worked with them that could help with these sorts of things so that they could keep dealing with all of the other things that they have to do, because they deal with employee health situations, they deal with outbreaks, they have to monitor, what's happening in all of the patient situations and all that sort of thing. So to pull them away to do these other things. But the con is you don't want to keep adding layers to your organization and maybe having miscommunications continue. So it has to be a very cohesive, well-run, thoughtful process, depending on too the size of your organization and the complexity of your organization. And is this something to be created? And I'm going to give a caveat, until we can fix all these gaps that are out there, which by listening to this, you just keep adding the years to how we're going to really pull this together.
Good comment. Thank you, Barbara. We do have another question from Gordon, but let's get to that if we have time in a few minutes. So maybe you could look at that as well, the three of you. But Joanna, we're back to you on our next, and we only have a couple more questions for today's webinar. We want to ask you this about digital tools like IFUs, QR codes. We all use those. AI platforms. How's that shaping the future of IFU adherence and overall patient safety and healthcare cleaning? And what other support or resources would contribute to the end user's ability to be knowledgeable and compliant?
Well, thank you for that question, because that is actually a burning question that many of us are really grappling with. There isn't a central repository for those types of documents and information that are readily accessible to the end user or to the user that's responsible for the cleaning and disinfection and the function of the device itself. So most healthcare organizations are required by law, usually state law, but also federal law, to train individuals on the use of their devices. Okay. Cut and dry. No deviation from that. The other piece of it is, okay, so how do you do that? And if you don't have a central repository, a list, I recently asked for a list from my biomed manager of all the devices in the ICU. It was pages and pages and pages of devices. Who has the capacity to know and understand the IFUs for all of those devices? And this is in one patient room, okay? So, and if we don't have digital tools, we're not gonna be able to go forward. Currently, my understanding, and I could be wrong on this because I don't troll the internet on a daily basis, but there's only one real source for IFUs, and specifically, it may only be associated with a certain type of device, a surgical device, although there are others. But so what's the repository? How do we get our arms around this? Well, it has to be in technology. There's no other option as far as having all of that information available for the end user. And, devices that have the capacity in the site, in the area within which the device is being utilized, can be the most effective in terms of giving people the information that they need, helping them to do what they need when they need to do it, providing, as Sarah mentioned earlier, checklists so that the steps are not missed in the process, and having that in a concise location electronically, whether it's on a screen, whether it's in a handheld device, whatever the case may be, for those folks that need that. Now, the end user in terms of the nursing staff may not have the occasion to utilize that on a daily basis. That's cool. I'm cool with that. But having those devices available for the people who do use it every single day is essential. And right now it doesn't exist. And so organizations are really grappling with those types of things that help people do the right thing at the right time, have them available for the end users, and this involves not just EVS, but biomed, every category of healthcare that uses a device. And I think you would be very hard pressed, especially in the laboratory, to have an individual that doesn't utilize some type of device in their regular workflow. And so I'm hoping that AI technology will give us that option. The fear is that, other than Benjamin Franklin, who never patented any of his devices, that it could be, open access. I doubt very much that's going to happen in our capitalistic environment. But the reality is there has to be some ability for people to access these devices without it being too much of a problem. And I sincerely hope that the regulatory agencies, although that might be a challenge in this environment today, to pick up the slack in terms of at least giving manufacturers and end users the guidance to have that information available to everyone. It would be great if both the FDA and the EPA would have those repositories. That would make it a lot easier for everybody and significantly cheaper, but that's a wish that's probably not going to happen anytime soon. But the reality is, if we wait for that to happen, I'll be long gone for sure, probably dead of a healthcare associated infection as a result. But the reality is that's what we need, and who's going to do it? Those of us on this webinar, those of us in HSI, the healthcare portion of ISSA, are really focused and dedicated to making that happen and creating that change.
Don't leave us yet, Joanna. We got a few years left, and we don't want to be too morbid. But hey, Barbara, put on your consultant hat. And before we get to Sarah on our wish list question, we want to talk about what you all wish. Gordon asked the question about, is it critical to have a breakdown regarding which IFUs are assigned to whom? So if you can see that. What do you think? Give us a quick response to that, if you would, Barbara.
Well, I pulled off an IFU DFU document that's recent. It's 360 pages long. So in there, you do have to coordinate, is this for the end users? Is this for biomed? Is this for EVS? Is this for everyone else to sort of learn? So it's not just that one person might be responsible in each area, but that's where the whole thing about bringing the whole, family together internally to say who is going to set the table, who's going to wash the dishes, all those sorts of things. So you have to have those implementation, and Sarah said it really well, of ongoing checks for all of those things. So yeah.
Okay. Good comment. Yeah, that's a long document. So just shows you that there's so many details. Okay, we only have a couple more points. We have a wish list question for you. If you could fix the world kind of question. Sarah, we're going to start with you. If you had the power to change one or two things regarding today's topic, you were given the magic wand. You got the power, Sarah. What would it be?
Well, just to add before we move to that, a couple of things. So what Joanna was saying about the training, the QR codes was one of the platforms that you talked about. And when we have a new piece of equipment that we're bringing on board, as Barbara mentioned, having that group together who identifies who's going to clean what, when, and where. But having those QR codes available on the machine itself can be a nice, easy way for somebody to get the information at the moment. So just wanted to call that out, that's another resource that people can use. And then back to the question that was posed in the chat by Gordon, that's a nice way to, as Joanna mentioned, in the ICU, we have hundreds of pieces of equipment and surfaces that are in a patient's room, and having a description of what EVS is responsible for cleaning in that room, what our housekeeping team is responsible for, what is nursing responsible for, what is biomed responsible for, really having it outlined so it's very clear. That helps to reduce some of the confusion about the responsibility. So just to follow up on those couple of things. And then for my wish list, and I'm sure others will have some to add, and these have all been mentioned, but I would say having the standard format for the instructions for use, so it's really super clear. Association for Professionals in Infection Prevention and Epidemiology, APIC, is suggesting the potential to outline it like you would see a nutritional label on food. So something that it's the same everywhere, and then people can understand how to use it. So that's one. And then having them readily available, which we've talked about a lot already. There are some tools out there that you can pay for a service, of course, to have these repositories, but even those are not comprehensive. So, making it available free for people in a format that they can understand. And then the second is really making sure that those IFUs are realistic, that they can be followed in real world scenarios, using products that facilities have on hand already, so that they don't have to try to make up something else or piece together what they can use in place. And with that, I'll pass it back to the group to see if there's anything that they would add as well.
Good ask for there, Sarah. And Barbara, let's go to you next, and then Joanna will tell us her wish list after that.
So my little wish list that I put down is that we need to continue to keep the FDA, CDC, EPA, manufacturers, everybody continue to talk about all this. Healthcare Services Institute that Joanna mentioned, that's part of ISSA and the healthcare platform at ISSA. We had a summit this last early April, which was still very cold in Chicago, and I didn't bring a coat. But we're having another one in May of 2026, maybe a little warmer. But it's keeping the conversations going, because we have to start closing the gaps between things and not just be in our lanes and hope it all works out once it gets to the patient, because the patient's in the center of things. And we're not thinking of that, all those ways of going through all of this. So there's too many little gaps that we have to do. So we have to keep talking.
So your wish list is in May. It'll be warmer in Chicago. I heard that.
Yeah, you heard that loud and
I
clear.
heard that. Yeah. All right, Joanna, what's your wish?
Well, my pie in the sky wish probably isn't as realistic as all of yours, but, I would really hope that the federal government, because they already have the structure in place with the EPA and the FDA and the CDC to have, well, although the CDC is a recommendation source, not a regulatory source, really have the responsibility of not just enforcement, but updating regulations and reviews to make people accountable. You know, the accountability piece, in my opinion, is misdirected. When you have an organization or even an individual who's the responsible person because they use it for the function of the device, that's misplaced, in my opinion. You know, as a nurse, my training is not about, you know, engineering or even cleaning. My expertise is taking care of patients and what I need to do to have that happen. And so, like I said, it might be a pie in the sky, especially in this environment right now. But I want to give one example of it because this is something that actually happened to me. I know we're going late on time, but you know, there was a device that was utilized by organizations that was outdated. And the device itself was a multiple use delivery system for IV medications or substances. And the manufacturer was marketing that device as it was originally validated by the FDA. Well, a significant amount of time, I want to say close to 20 years, had elapsed from the original validation of that device. And many things have happened, like outbreaks of, you know, significant diseases, hepatitis, all kinds of bloodborne pathogens related to multiple use vials in the healthcare environment. You know, people died with this stuff. And the manufacturer wasn't required to change not just the device, but the use of the device, because the validation occurred in 2001. And here we were in, you know, 2019, pre-pandemic, you know, dealing with something that was blatantly in error. And those are the kinds of things that I would hope that, you know, the regulation would serve to really be the most appropriate for the patients. You know, the FDA has a website where you could report sentinel events and issues with devices, substances, and medications and all kinds of things. But I don't know where it goes into the black hole. Let's just put it that way. I'm sure somebody looks at it at some point, or it's cumulatively of whatever. But, you know, those are the kinds of things that would make the end user. Why is it always the hospital or the end user that's ultimately responsible when we have no ability or control over the process? To Barbara's point and Sarah's, and why we're all here in the first place, is to address the issues and create potential for change. And that's basically the thing that we can do to make it a better environment for everyone. And unless we collaborate, as Barbara said, unless we keep the conversation going, unless we initiate programs that move us in the direction that we need to go, this will continue to be a huge issue. And the regulation at this point in time is against us. For example, the Joint Commission has standards now for hospital environments and infection prevention and laboratories, requiring the IFU accommodation, when even some manufacturers give documents and instruction, as Sarah said, when they come to in service on the device, that are not aligned with the manufacturer's instruction for use. And so the end user is in a position where, well, the manufacturer told me about this. What's going on here? And then you're saying that it's not in line with the IFU, and you're going to cite me and not the manufacturer? That doesn't make any sense to me. But the accreditation piece is huge, especially when it can jeopardize reimbursement and licensing for hospitals. So it's a big deal that needs to have a big change, and only us, when we collaborate, did I say that right? That's probably bad English. When we collaborate, are the ones that can really initiate the process and the change in the right direction.
Collaborate works for me.
For today.
And I think we need that magic wand, because yeah, it's going to be a road to go down to make all this come together. But that's why we're doing this today on this webinar. We want to get some closing thoughts from each of you as we wrap up. We're a little over time. Thank you to the audience for sticking with us. But let's start with you, Barbara, and then we'll go to Joanna and Sarah. You can have the final word, okay? All right. So, what should manufacturers, EVS, and healthcare institutions be doing today?
So we have to loop in regulatory and guidelines organizations as well into that loop of folks. But what I've been telling folks for the number of years, but lately, you need to look internally within your own organization with all of the facts we've given you today and understanding I have issues. What are those issues? And how can I control what I own in those issues until we can get everything all set? So look internally and know what you need to do that we've mentioned that you may not be doing today is a good start.
That's a great answer. Joanna, what would you like to see them do today?
Well, I'd like to see more collaboration with for the end users, for the organizations, with both the manufacturers of the device and the chemical companies that and that's, I think, what we're trying to do with HSI and ISSA, to bring together those folks to create a path and a template so that the regulatory agencies can just pick up the slack and kind of proceed with what we feel is the most important thing.
Thank you. And Sarah, is the well dry, or do you have something for us?
No, I would just say, I think, as Barbara mentioned, just awareness to this situation, understanding where you are today, what you have the capacity to change in your day, and then advocate where you can. This is a good first step, just trying to make sure people know that it's an issue, and then how do we make a change for the better for the future.
Thank you, Sarah. Well, I want to thank Barbara, Joanna, Sarah for being here today, and our audience as well. Like I mentioned at the outset, we will have a recording of this ready in a few days, a full feature article outlining everything that was mentioned, and that'll be delivered to you as well. It'll be on cmmonline.com and issa.com as well. So thank you all, and we'll go clean something properly.
Thank
Thank you
you.
very much.
Bye-bye.
Thanks, everyone.